Okay, so my quick assessment, I talked about them here. Now I have these videos. I'm talking in these videos, explaining to my patient what to do, but for some reason, Bridget and I tried it and you guys can't hear it. So I'll just verbalize them while you watch the video. Apologize for that. So here she is looking at the smooth pursuits, following the red ball as she tracks it from side to side. You can see her eyes. She's kind of refocusing quite a bit. She's not having too much of a hard time. Her head's not moving, but she did kind of refocus and refixate, and she verbalized uncomfortable feeling with that activity. Here with the saccades, I have her going back and forth to the red and blue ball. She kind of has to blink a lot, refixes her eyes quite a bit, and she looks kind of annoyed. That's kind of my go-to. That's not fun for her, and I gave her a grade of a 3 on that one. And here is the vertical performance up and down. This one typically people have the most trouble with. I think it's just an unusual eye movement anyways, but that's the kind of what we do there. So typically I do this for about 20 seconds. I think when my doctor performs it, so not the optometrist, but the medical doctor team, they kind of do it like for 5 seconds, which is helpful, but I feel like you get more information if you do it for the whole 20 seconds, because you can kind of see how time definitely affects their performance. So just keep that in mind. These videos are about 9 seconds long because they wouldn't fit in this PowerPoint otherwise. So this is just a snippet of the whole test. Okay, do those. All right, so then we have the near point of convergence. Here I have a piece of, I have a ruler or a tape measure here. She's holding it to her chin, okay? And I'm taking the my dowel with a little ball on it, the fixation point, and bring it to her nose like this. So keep that in mind. That's what I'm doing. I'm looking to see where she has a break, meaning where she's unable to keep the incoming object single, and then when she can recover. Okay, so I pull it in. I ask for a tunnel double. I'm also looking at her eyes when she performs this task, because even if she doesn't recognize that it's not single, I can tell if her eyes deviate in any area. So sometimes it's not just asking for them to tell you if it's simple, it's watching their eyes to see if you agree that they're focused on that object. So I'm coming into her nose and she's watching it and telling me what she sees. So I'll kind of play that video here. And she's saying 2. I'm giving her a second to fix it. She can't, I pull it back. She tells me when she recovers. Okay, so she kind of had a break of, I'll say break of 5, recovery at 12. That's a pretty significant break, or pretty significant disparity between the break and the recovery. We want that to be at or very near the point of break. So this example here, she had a pretty exaggerated break or recovery from the break point. All right, so then I also, during the assessment of the near point of convergence, I kind of asked for her to, I like to pick up to see if she's having that physiologic diplopia. So physiologic diplopia would be just normal double vision. When you're focused on something in front or behind, what you're focusing on is single, the other object should be double. So in this picture here, you'll see she's looking at this red ball that she has in her hand and the pink paper on the door behind her, or behind the ball. When she's focused on the red ball should be single, the pink paper should be double. Vice versa, if she switched her vision to look at the pink paper, the red ball should be double, the paper should be single. So a lot of times when I'm having someone do, let's say, a near point of convergence, they'll go, well, you're double, while they're looking at the incoming object. And I'm thinking, I tell them, that's okay, that's actually normal double vision. And then if they tell me that that kind of comes and goes, I might look at this activity, just simply holding something comfortably away from their face and having something far away and having them switch back and forth between the near object to the far object. Nothing too close to their face like this. That's just going to push them more into being more uncomfortable than they already were. But just a nice distance. If she's holding it here in front of her face, maybe at least, 12 inches or so, she should be able to go back and forth between that distant object and the near object, while simultaneously being aware that they're double if she's not looking at them. Now, that's very easy for us to talk about, but very difficult concept for someone with a mild TBI, because it is predicated on the fact that they have to have that good divided attention, which is something that all of my patients, well, all is aggressive, but many of my patients have a really hard time with. So we'll talk about that more also as I go along. I've mentioned this before. I use the DEM. That's one of the more common tests that we have here. It's an easy exam. It's an easy test. We can do that. I do it because I like that it's normed. It has time values, and it gives me an idea of how quickly they should be able to read the numbers. I can track for errors and things like that. So this is an assessment that I use pretty routinely upon evaluation.